At University Hospital and Medical Center, I perform the laparoscopic adjustable gastric band. At Northwest Medical Center, I perform the laparoscopic band, the gastric sleeve, and the gastric bypass. Oftentimes, patients don't come here as their first stop in the journey to weight loss. They've typically tried a lot of diets, typically most of them, and they've been successful in losing weight, but they've been unsuccessful in maintaining the weight loss. And my job here is to not let them think this is a magic pill, but let them know that, again, this will help them stay on track when it comes to the eating portion of diet, but it doesn't help with exercise, and you have to commit to both in order to be successful. Before any sort of bariatric surgery procedure, we need to make sure that the patient is cleared psychologically, also has meetings with a nutritionist and also with their primary care to make sure that if they have any conditions such as hypertension or diabetes, that they're currently under control. Laparoscopic means minimally invasive, and it means using multiple small incisions instead of one large incision. 10, or I should say 20 years ago, most surgeries were done the old-fashioned open way with one large incision. Now we do surgery through a laparoscope, which is a small camera inserted through one small incision and other small incisions to use our instruments through. The end result is a quicker recovery and less risk of hernias and wound infections. I always tell my patients that any of the surgeries we perform are just a tool to help them get to where they want in 2 or 3 years from now. It's going to help them stay on track when it comes to eating and eating properly, but I always emphasize that exercise is an important part of maintaining the weight loss. If you don't exercise, even if you eat perfectly, you may not be happy with the results 2 or 3 years from now. And exercise is the proven way of not only getting to your goal, but maintaining it. Well, I've been in South Florida for 7 years, and I've been doing bariatrics for the past 6. So I've seen results, and the typical results definitely vary, but usually after 2 years, we'll typically see anywhere from 60 to 80% excess weight loss, depending on whether they've had the band or the bypass. But after 2 years, oftentimes the results are similar between the band, sleeve, and the bypass. But I will say that the ones that are most successful all have one thing in common, and that's typically exercise. The 3 different procedures are the laparoscopic adjustable band, the laparoscopic sleeve gastrectomy, and the laparoscopic gastric bypass. And I think of them as almost a continuum, of the least invasive to the most invasive, but the one that leads to the most weight loss versus the least amount of weight loss. So the laparoscopic adjustable gastric band is placing a device that helps restrict the amount of food that you can eat. It requires adjustments here in the office and close follow-up. The laparoscopic sleeve is trimming the stomach into the shape of a tube, and it's naturally going to restrict how much you're going to eat, but removing the other portion of the stomach also naturally decreases your appetite. The gastric bypass has a creation of a new tiny stomach pouch, but also requires bypassing the stomach, which leads to malabsorption. So again, you lose most weight because you're not able to eat as much, but what you are able to eat, you're not able to absorb as much. So again, you have the most aggressive weight loss with the laparoscopic gastric bypass. Before surgery, I typically have my patients do a 2-week diet before surgery, and the goal is for them to lose weight and to actually shrink the liver in that period of time. We found that this little pre-op diet actually helps me in the operating room because if the liver is a little bit smaller, it makes my surgery technically easier. I'm not looking for them to get a start on the weight loss process. It's just for help in the operating room. The process of determining which is the best procedure is often personal. So I'll often give an information session or lecture where I present all of the information, but I'll never tell a patient that this is the surgery you have to have performed. I'll give them all the information, and I'll typically guide them to which one I think will benefit them or suits them the most, but it's ultimately up to the patient and their family to make the final decision with my gentle guidance. Well, typically right after surgery, they're obviously going to have some discomfort for the first couple of weeks. That typically fades away, and fatigue is one of the main issues that we deal with for the first month. But as the body adjusts to losing so much weight so rapidly, the energy typically comes quickly back. The follow-up is usually 1 to 2 weeks after surgery. I'll see the patient in the office and typically have a look at the wounds and likely remove the sutures. And then at 1 month, 2 months, and 3 months out. And after that, I typically like to see my patients yearly to make sure that they're still on track. I've seen quite a few patients, and it's fun to see them come in at the beginning of surgery with a lot of energy, and it's always fun to see them 6 months to 8 months out, happy and doing well. The laparoscopic adjustable band is a device that we place. It has 2 parts. It has the port and also the adjustable gastric band. I place it laparoscopically. The adjustable portion is placed around the top of your stomach, and it creates restriction, allowing you to eat a little bit slower and thus lose weight. The port part is placed just under your skin, and it allows us the ability to adjust the gastric band in the future. So this is a model of the laparoscopic adjustable gastric band, and you can see there are 2 parts to the band. First, there's the adjustable part that's placed around the top of the stomach. Again, this is placed laparoscopically, and this portion is similar to an inner tube that, again, when it's adjusted through the port, we can make this tighter or looser. And again, the other important part is the port itself. We can use a special needle to adjust this, and by putting the needle in here, we can add or subtract fluid from the band itself. The ideal band, when it's adjusted, slows things from moving down from the esophagus into the stomach. Not so slow that it doesn't allow things to go down and creates vomiting, but just slow enough that it creates satiety. The advantage is that it is adjustable. It's something that we can adjust here in the office or actually in the hospital. So if you're losing weight, we can oftentimes leave it alone, but if your weight loss has plateaued, we can adjust it and give you a little bit more restriction that's helping you lose a little bit more weight. Typically, most patients that are candidate have a BMI of greater than 35 with some comorbidities such as hypertension or obstructive sleep apnea, or a BMI of greater than 40, and they don't necessarily have to have comorbidities. The gastric bypass is another minimally invasive procedure that we perform. We start off by creating a new small pouch out of the top of the old stomach, and we bypass the old stomach. It's still left in there, but it's bypassed. The end result is a surgery that you lose weight because of restriction. You now have a tiny new stomach, and also malabsorption because you're bypassing the old stomach and a lot of the intestine that helped with absorption. The advantages to gastric bypass are more aggressive weight loss compared to the sleeve and the laparoscopic band. It also benefits those patients with type 2 diabetes. The gastric sleeve is also a minimally invasive procedure where we actually trim the stomach. The stomach right now is similar to the shape of a football. We trim it into the shape of a banana. So when you eat, you're restricted. You can't eat nearly as much because we've removed the part of your stomach that actually stretches. The other important thing that we do is we're removing a lot of the appetite-producing hormones that are produced in the part of the stomach that we remove. So your appetite is naturally decreased after the gastric sleeve. So this is a model showing how we start the sleeve gastrectomy. We would actually take our stapler, and using a protective bougie to size this, we would use our stapler to actually remove most of the stomach. Again, the stomach in the beginning is shaped like a football. After we're done, we'd have it shaped like a banana. The end result is restriction, and by getting rid of this portion of the stomach, this is the portion of the stomach that actually stretches and allows you to eat more. It also produces appetite hormones, which we will get rid of also. The benefits with a sleeve are a more natural weight loss process because your appetite is naturally reduced at this point. So not only are you restricted, but you don't have the drive to eat as well. That leads to more gentle weight loss. A candidate is similar to the band or the bypass. Typically have a BMI of greater than 40, which usually means you're roughly over 100 pounds overweight, or a BMI of 35 or greater with comorbidities such as hypertension or sleep apnea, or a BMI of greater than 40, and they don't necessarily have